My name is Sandile Mahlangu. I'm happy to be here today. May I kindly welcome you all in today's session. I hope I'm audible enough. Today we are having this wonderful session. Thank you so much for joining in today. I'm Sandile Mahlangu, working for Eswatini Hospice at home, and I'm happy to be with you today. May I request that today's session we kindly ensure that we keep our cell phones muted. If ever you are joining with someone else, I will kindly request you to introduce yourself and the people you are joining with on chat. You will only write the name of the person and then the profession or position, and then the place you are joining from. So if you are 4 or 5, you will name yourself and then the people you are with and their position and the place you are from. So we are going to look at today issues of ongoing goals of care. But before we can go there, may I request that we introduce ourselves so we may address one another very well. So I will start with Sis Messi. May you introduce yourself, your name and the place you are joining from.
Thank you, Mr. Mahlangu. Good afternoon, colleagues. My name is Mercy Shabangu. I am a social worker at Eswatini Hospice at Home, and I am part of the Eswatini Hospice at Home ECHO team. Thank you.
Thank you. May I request Victory Shabati to introduce yourself.
Good morning, good afternoon. I'm Victory Shabati from Manzini Government Hospital.
Thank you, Victory Shabati from Manzini Government Hospital. May I request Zodwa Kamete to introduce herself.
Good afternoon, team. I am Zodwa Kamete, working for Eswatini Hospice at Home. Thank you.
Thank you. I've lost Nana, so I don't know where Nana is gone. Victor, is Nana with you there?
No, she's not with me, but.
Okay, maybe they've already taken the electricity. They were saying they've a challenge with electricity there. I will continue to trace them while we are still going. And may I request that we write our names on the chat so we may remember who is who. Today we are going to look at ongoing discussions of ongoing goals of care. And before we can even look at the ongoing goals of care, these days we are treating a good topic, which is very critical, and it's a pillar of palliative care, which is communication. So this is the theme we've been treating in the past 2 months, if not mistaken, and then we are going to continue to do it until early August. The reason we are looking at it is because it is the pillar or the backbone of care, especially in palliative care. Without it, we cannot do it correctly. So we will be treating this topic. We've been treating this topic for some time now. We started with the elements of communication, then we look at how to hold a meeting. And then last session, we were discussing breaking bad news. So today we are looking forward to do the ongoing, but before we talk of ongoing goals of care, we find it correctly or to be good that we start with the ACPs. because before you can then be in an ongoing discussion, you have to start from somewhere. Just after breaking bed news, then you need to start on advanced care plan. So we see that these topics like they act like a domino. First of all, you need to acquire the elements, the skill of communication, and then you move on getting the skill of holding a meeting, because in communication, especially in palliative care, you engage on meetings between the patient and the team itself and the family. So it's meeting after a meeting. So we discovered that after we have broken the bad news, there's little that you discuss. So we couldn't rush straight into ongoing, but for us to discuss ongoing, we will start on the advanced care planning process, because the first thing you need to do before you do the evaluation on the ongoing, you have to start with the advanced care planning process. So just after breaking bad news, we then engage on advanced care planning. So Sis Mercy today will carry us through that. So I'm hoping that our Manzini hospital team will be connected by the time we are done the session. We are still trying to find them, where they've been now. So may I request Sis Mercy to share the presentation with us on ACPs, which is advanced care planning. I hope you are ready, Sis Mercy.
Yes, Mr. Mahlangu, thank you so much.
Okay.
I hope I'm audible to everyone. So as Mr. Mahlangu has mentioned, today we're going to look at advanced care planning, as we felt like it is important to start with that kind of care planning before we can even have ongoing goals of care. So with our topic today, we are going to define the key terms in advanced care planning. And we are also going to explain the importance of holding the advanced care planning meeting. We will discuss the process and when to have the advanced care planning discussions. Then we will look at the barriers to advanced care planning discussions. We will then demonstrate how to initiate this kind of directive conversations and when we should not have advanced care planning discussions. So advanced care planning is a process of discussion and reflection about goals, values, and preferences for future treatment in context of anticipated deterioration. And we have noticed that it enhances the end of life care because it ensures that the patient's voice or the client's voice is being heard. And it basically serves as a valuable guide to the healthcare team. And then the second term we are going to look at is the Advanced Care Directive, which is a document where the person can write, or the client can write down what they would like or not like to happen in relation to their medical treatment. So it is usually written down in statements. And then there's the proxy decision maker. Now, this is the person that is appointed by the patient through the advanced care statement, as we've mentioned it above, to make decisions on his or her behalf related to the healthcare. So in situations where the proxy decision maker, actually we are encouraged to talk to our clients about having a proxy decision maker, because there are situations whereby you find that because of the deterioration of the condition, the client can no longer make decisions for him or herself. So it is important that at the very beginning of the advanced care planning, the client is able to select their proxy decision maker to ensure that whatever form of treatment or therapy the client is going to get is in line with their wishes, their goals, and their understanding about their condition and everything. Then there's the durable power of attorney for healthcare, which is also another term. So here it's a legal document that gives the proxy decision maker the power to act on the patient's behalf. And then there's the living will, which is a legal document that allows people to state their wishes, their preferred priorities of care, if they become unable to communicate. So it could include anything with regards to their health or even their personal things. And then now we are going to look at the benefits of care planning. So the benefits of advanced care planning is that it improves the patient care. Now, the patient care is improved in the sense that the patient has the right amount of information and the right kind of information from the healthcare worker, which now helps the
sorry
client.
to interrupt you. I'm really sorry. Are you moving your slides, because we are on the introduction slide?
Thank you, Alina. Please share the next slide, Mr. Mahlangu. Thank you. Sorry, colleagues, for that.
It's still, if you could reshare the screen, because I can still see the introduction slide only.
Are you done with the terms?
Yes, now we are on the benefits.
Okay, sorry.
Yeah. Thank you.
It's perfect. Thank you.
Thank you. So we are looking at the benefits of advanced care planning. We said that it improves the patient care. And we state this because the client has received enough and appropriate information, like I said, about their condition. Hence, they're able to make better informed choices, which those choices will be more in line with the care and kind of support that the patient or the client needs. Another benefit is that as the patient lives with advanced illness, it then provides the specific guidance in making clinical decisions, which are basically in line with the care and support that is preferred by the client. It also improves the population health, because if we have the right information, or if the client has the right information about their illness, they are able to actually seek appropriate therapies or treatments, which helps them not to waste a lot of money in things that will not help them, or even wasting certain resources. It also decreases moral distress, and it decreases conflict, because in this case, the main thing here is that the client has all the information that they need. And from that kind of information that they need, they're able to make better informed. No one would have kept anything from the client. There will be no conflicts in terms of, had I known better, or had I had all the facts, I would have chosen this and that in terms of my treatment or in terms of my therapy. It also shifts time spent on crisis management, and this time is shifted to quality of time, which will be spent in supporting the patient with their wishes and the decisions that they make. Another benefit is that it results to high perceived family satisfaction and less stress and anxiety for the family members. So now we are going to look at the advanced care planning process. So in the advanced care planning process, we focus on setting the goals of therapy. With the goals of therapy, it could be goals in relation to the chemotherapy if that client needs chemotherapy. So the goals of that chemo that the client is taking, it could be goals of the dialysis or physiotherapy. Any type of therapy that the client is undergoing, there needs to be goals that we set with that client. And then we also develop care directives. So in this case, we are basically answering the who, where, and what questions. So who will be involved in the care of the client? This could also include the proctor decision maker and other people that the client consents to. And then it could be where the client wants to get treatment from. Sometimes they will prefer home-based care instead of being probably hospitalized, or they could even prefer hospice care. where applicable. And then it could also be what kind of support does the client want. So these kind of care directives can even be written down in statements, as we've mentioned before. And then there's making decisions. Still in the process, there's making decisions about specific forms of medical therapy, which also comes in the form of statements. So now the client is able to say that, because the client will be told what kind of therapies they are going to receive, what is the goal of the therapy, and they would have chosen where to receive that kind of therapy. So now they are going to be able to make choices like, when it gets to this point, I probably am not comfortable with such and such therapies moving forward. If probably the way I react to certain treatments is not a positive one, then this is an alternative that I would prefer. So as we are working on setting the goals, on developing the care directives and making the decisions, it is important to consider the culture of the client and to consider the health literacy. How well versed is the client in terms of health related information. We are also looking at the language that we are using with the client to ensure that they understand absolutely everything that is being discussed. And we also consider their educational level so that we are able to use terms that will be very simple, clear, and plain to them. We've mentioned most of these things even in our previous sessions, because we are still discussing communication. So you can also visit our YouTube channel just to get a clear picture of what we've been talking about, because some of these things are sort of like a link or a repetition to what we've been discussing before. So still in the care planning process, it is also important to respect and support conversations related to death, dying, or planning at the end of life, and discussions about limiting the use of life-sustaining technology. So even in this process, we do not rush anything with the client, but we take the time with the client. We've been emphasizing that we walk at the pace of the client. As we've mentioned in our objectives at the beginning, that we are also going to look at when not to continue with advanced care planning process. So it is important to observe as we engage with the client. And all of these things that we are discussing in the process are very important to consider and follow, even if the team disagrees, because our understanding is that we put the client first, and we suspend our personally imposed beliefs or values. Now we are going to look at when to consider advanced care plans. Please move to the next slide. Mr. Mahlangu, please open the next slide for me, not this one. Thank you. So when to consider advanced care plans? We consider advanced care plans on assessment of the individual need. The moment we meet and assess the client, we work on advanced care plans. But as we've mentioned, there are moments where, for example, after breaking the bad news, we do not rush the client into such things. But because we have already built a rapport and we are going to be moving and working with this client along, we have it in our plans to do the advanced care plans with our meeting, with our clients. We can also consider advanced care plans when the patient asks. They could ask questions like, so what is going to happen when I get at this point? What is going to happen when I can no longer walk or talk? So this is where we can also initiate the advanced care plan. When there's also a life-changing event like the death of a spouse, maybe the client has lost a very close relative or a friend. This is actually a good opportunity to actually talk about some of the things that we think or that we find difficult to discuss with our clients. That, you know, as it happens like this and this in life, what will happen, or what would you prefer if a situation like this would come up as we provide care for you? We can also consider them when following a new diagnosis of a life-limiting condition. As soon as the client is diagnosed with a life-limiting condition, we work on advanced care plans, because we do not know how quick the trajectory of the client might even go to the point where probably they can no longer be as functional as they were before. So it is very important that at the diagnosis of a life-limiting condition, we start working on the advanced care plans. Even in situations where there are now multiple hospital admissions, I think at the beginning when we were talking about what palliative care is and when we were looking at the trajectories, we noted that at some point, there's usually a multiple hospital admissions. And in most cases, those are basically showing that there's a huge deterioration in the health of the client, because even if the client comes out okay, but their health now is no longer in the same level that it was before the client went into the hospital. So we should avoid a crisis. But as soon as we notice that this client is coming in for multiple admissions, now we initiate the advanced care plan meeting. And also on admission in a healthcare facility, we make use of the time. As soon as we admit the client, we make sure that we have all the information in terms of who their proxy decision maker is and what they would want to happen in terms of the kind of treatment that they're going to receive. Now we're going to look at when we should not, yes, thank you, when we should not conduct advanced care planning. So when the patient lacks capacity, we do not force such meetings with the client, because in this case, clearly the client will not be able to make the right decision. The client.
You were cut, Mesty, sorry. May you repeat a bit? We lost
Okay.
you, yeah.
Oh, okay. Sorry, colleagues, for that. I think there's probably an issue with my network. So when we are looking at when not to conduct the advanced care plan meetings, and we are saying that it is when the client or the patient lacks capacity. So in situations like this, it is not advisable that we continue with advanced care plans, because the client probably doesn't understand what is going on, or the client won't even understand any information that we are sharing, and they won't even understand the importance of such a conversation or a meeting. So it won't be fruitful at the end of the day. And in cases like this, or in situations like this, we basically rely more on the proxy decision maker, if the proxy decision maker has been selected, which is why it is important that we really make a follow-up or ensure that our clients choose their proxy decision makers. And also, this is where we can rely on the family members in terms of what goes on with the client in terms of their therapies, when to stop what, when to initiate what in terms of their treatment. Then we also avoid it when the level of distress are high, and this can wait. As we've mentioned before, we were talking about how we conduct a family meeting, how we break bad news. So in most cases, after breaking bad news, you find that the client is very emotional at that point. They are still trying to process or make sense of what has just been said. So in situations like those, the levels of distress are very high, and the client won't even be able to follow through on what's happening. So we are advised to wait and probably schedule another meeting to conduct the advanced care planning meeting. And when the patient gives verbal or non-verbal cues that they're not willing to engage, we do not force, in as much as these things are very important to consider and to do, but we do not force the client whenever they are not ready, but we walk at their pace. And we are giving them this kind of information in small bits so that they can be able to process it, so that they can take their time. And we are empathetic as we are working them in such issues. So whenever they are giving cues that they're not willing to engage, we respect that, but we always try to initiate such talk. Now we are going to look at the barriers to advanced care plan discussions, sorry. So some of the barriers that are here during these discussions are the reluctance of health workers to initiate such discussions. Sometimes you may see that the client seems healthy enough, or you may see that the client seems to be responding well to treatment. Gansi, we do not know when the situation might change or when the condition might deteriorate. There's also inaccurate prognostic information, where basically the prognosis of the client is not quite accurate, so it becomes a barrier to the discussions. There's also poor estimation and inaccurate reporting of survival times to patients. So not having clear information on such also acts as a barrier. There's conflicting information from various team members, where probably one team member will say something that is totally opposite to this one. Someone may say, oh, there's actually a cure or a treatment that works for such, and the other one says, actually, there's no treatment that can help you at this point. So now it becomes a problem. There's also unsustainable information on the internet that further disparity, or that furthers disparity in prognosis, as we understand also that our clients or our patients are able to also gather information by themselves. So you find that the information that they can probably gather is different from what the test results regarding their conditions actually present. Another barrier is that the patient can wish to hear optimistic information. So it becomes difficult for you as a health worker to actually crush their hopes. Now we're going to look at how to initiate advanced directive conversation. So we are just going to quickly go through these. The examples that we've set here are not the only, they're not the only questions or comments that you can actually use. There's a lot more that you can actually use to initiate these directive conversations. So what we look at when we initiate such conversations is that we normalize comments and questions. So an example we picked here is when you could tell the client that you would like to discuss the topic. So I'll read it as is. I would like to discuss a topic I bring up with all my patients. So in this way, the client will understand that this is a very important topic that you want to discuss with them. And it's not something extremely rare, because it is a thing that you do with your patient. It kind of makes it, I don't know, a bit normal or acceptable to the client. So now this also prepares them mentally that, okay, we are going to have a certain discussion now. You can also inquire the understanding, the patient's understanding of the illness. We've been putting emphasis of this from the beginning of our discussions and communication, that it is important to know where the client stands or what the client understands about their condition. So a question we can use here is, what do you understand from what the doctors have told you? In this way, the client will be able to say it most likely in the way that they interpreted or they received the kind of information. We can also inquire to elicit hopes and the expectations from the client. And an example of a question we could use here is that what activities or experiences are most important for you to do to maximize the quality of your life? So here the client is able to actually express themselves, and you can see that what are their hopes basically, and how, or what are their expectations, how high or how low are their expectations. And then we can also inquire to elicit thoughts regarding well, in situations where it's applicable, the cardiopulmonary resuscitation. So here we could ask questions like, have you given any thought to what kinds of treatment you would want or not want if you become unable to speak for yourself in future? So the client, in this way, these kind of questions are not close-ended, but they allow the client to actually elaborate on the issue. But in a situation where the client is unable to answer such questions, probably because their condition has worsened, this is where the family plays the role, or this is where the family comes in. So when we engage with the family, we could ask them if the patient ever told anyone what he or she wanted for him or herself. So if the patient had any discussions about what they want with regards to their treatment, this is when the family can actually say, oh, at this point she said she wanted this, or at this point he said he would prefer to be treated, or he would prefer to be cared for at home or in the hospital. So in conclusion, colleagues, advanced care planning should be an ongoing process of communication. So because we've had the discussion today, doesn't mean that whatever the client has said at this point is going to be applicable throughout their course of care. Because sometimes as we take care of the client, a lot of things can happen in their care. They could improve, or their conditions could worsen. So the changes that happen along the way could also influence the care plan that we had initially set or discussed with the client. So it is important to continuously have this communication with the client. And advanced care planning should be reviewed and updated regularly, because we won't be having one session, we won't talk for once, record it and keep it that way, but because we'll be continuously engaging our clients, hence it will be reviewed and updated regularly. And also to check with your client if they still are comfortable with some of the things that were discussed in previous sessions. And then they are integrated into routine, patient-centered and preventative care. So as we work with our clients, advanced care plans are always integrated into our routines. And we ensure that the advanced care plan is appropriate to the client, and it is staged to the individual state of health. Thank you so much, colleague.
Thank you, Mercy, for such a wonderful presentation. I guess, colleagues, we have learned today that one of the things after we've broken the bad news to our client, then we move to the next step of coming up with a plan, planning for the future, planning in advance, looking forward. So today I've got that once you have broken the bad news in that meeting, whether it was with the patient or the family, you then schedule for another meeting so you don't bombard the patient with a lot of information. And one of the agendas of the next meeting may include setting up the advanced care plan going forward. And then we have seen how important it is to have the advanced care plan, which includes setting up the goals of care and then reviewing them and finding out what we need to do. In fact, in this meeting or in this type of communication, we hope for the best. We don't crush the patient's hope, but we are planning for the worst. Should the worst happen, what should we also do? So we also engage on that. Another thing that I've noted that this is an ongoing process, and the Mercy stressed that it needs to be initiated as early as possible in life. So right from the time when we have already found the diagnosis, we needed to kickstart the advanced care planning. I don't know if colleagues, you have something to say. You are free to raise your hand, and I can see Victory. You can also put in chat your question or comment. Victory, may I give you this opportunity to share something or ask a question?
Thank you, sir. Thank you very much for the wonderful presentation. My concern really will be, is it advisable or is it possible that we could have a duplicated care plan, one with us as a facility, probably one with the proxy or the family? Thank you.
I think that can be working very well with the team. The challenge may be the economy level, that you may find that if the patient will come every time, we have a duplicate. In fact, what happens is an advanced care plan, it's very important that the process decision maker knows this back and the front of the patient and is aware of what is happening, so that in case the patient now becomes confused, the decision maker is aware. So I think what you are suggesting or asking can be a good idea, that once we have agreed on the plan, and then we have a copy for you and for us. But for the next visit, we need to be cautious that we need to update it. Once it is changed, it must be changed even for the proxy. So he doesn't come and bombard you in the facility, yet he was not there when it was changed. I think it's good. The challenge may be the paperwork and the other ones. I don't know if you are answered well, Rita.
Yeah.
Thank you. Anyone else with a question or any comment to add to what Victoria has asked? You can write on chat or you can raise your hand and request. But what we need to note here is that if we are going to put a good plan together with all the stakeholders, the team itself, one of the things Messi said here is that you find that one of the things that delays the care of the patient is that you will find that among the team members, some will say the other and the other one will say another one. I can see a hand from Nana. You can say it, Nana.
Oh. Hi, team. Hello.
We hear you, Nana. You can
Yes,
say your
we
question.
can hear you.
Oh, okay. Thank you so much for the presentation. It's one of the difficult ones to tackle, particularly when you're still starting. We have a concern regarding the advanced care directives. You may have a client making one, and we usually say they are subject to change from time to time, isn't it? And then you also have a proxy decision maker who spends quite a lot of time probably with the client. It's probably somebody she or he trusts so much. Then you find that at some point the client is not able to make, she doesn't have the capacity to make probably a viable decision. Then the proxy decision maker might want to take decisions according to her wishes, not what they had discussed with the client. How do you strike a balance between what the proxy decision maker wants and what the client would have wanted?
Thank you. I can see this is Tandazi.
Oh.
Okay. I don't know, Messi, do you have something to say before I can share something? Or Gamete, do you have to say something, guys, before I can say something?
Okay. Thank you, Puti. Thank you, Tandazile, for the question. I think these are things that can actually happen as we take care of our clients. But what is really important is that we mentioned that during the advanced care planning, we actually have advanced care directives where the client is actually able to write down what they want for their care. So as we make the discussions, because we did mention how we initiate such conversations, these kinds of plans are not just limited or are not just short-term focused, because we look at what could happen in the long run as we take care of the client. So it is important to have these documents in place, because we talk about updating regularly with the client and ensuring that everything is documented well. I think these are some of the things that we can actually produce when the proxy decision maker is present to say that this is what the client wanted. It becomes a pity if there's nothing that was actually written down by the client. Thank you.
Thank you, Messi. Yeah. Mike Gamete, do you have something to advise in a case of the relative now wants to say things because the patient is out of capacity?
She tells you that's what she said just recently.
Okay. So what I think it's a pity, Tandazila, in such a situation. That's why we are advising that just after diagnosis, after breaking the bad news to the patient, let's schedule another meeting so that we can plan for the future, which is what we say through advanced care planning, sitting down and drawing the plan. But the situation, one of the things Messi said, how to initiate, was that you need to ask the family, did the patient or the loved one ever tell you what he or she wanted? That's the critical thing. And In our public health units, we need to educate our people to share their interest in terms of healthcare and otherwise. Sharing with your family members. Usually in my presentation, I usually say, when is the Passover, the death of Jesus Christ? We need to talk about death in our house. If that can find me, so that the relatives then, when you are unable to speak, they will remember that what did you say concerning your care. So I think it's unfortunate when the patient cannot consent or cannot say anything in terms of care due to capacity. But we are saying those cases may be there, but to those ones who are still able, let's kickstart it before we end up to that, because the only thing that will work and help you as a healthcare worker, when now you have these people who wants to overrule the patient, is then now to draw in your strength of ethics. That's why in our presentation, we started with the ethics. So that should then the relative decide to do things for the patient that are unethically or not gonna benefit the patient, we are able then now to hold on the strength of ethics and have that discussion with the decision maker, analyze it. In fact, we go back to a drawing board, we sit down and discuss. Yet you are a family, you want this, and this is what you say. And then we'll draw strength from the ethics. I can see Margaret Kamet's hand. I can give you Margaret, then I'll go back to Tandazi, and then we close. Yes, Margaret Kamet.
Thank you so much, colleagues. Thank you, colleagues, and thank you, Chair. My contribution would only be that there are circumstances we cannot avoid. If the proxy at one point in time now decide to change whatever the patient had put in place, it would be a challenge. However, it's something we cannot avoid because the proxy and the patient have been together for some time. And if she says this is the way to go, it will probably be the final word to go or the way to go. Ours is only what has been shared here to do the proper communication, do the planning while we have time, and then emphasize to the proxy in case he or he wants now to change something, to say, it might haunt her in future. Like Eswatini know very well that the last words of the person are very important. So if she decides to change something that was quite critical for the patient, while he or she could make decisions, it might not be well with her because we want someone to say, I'm sorry, I changed what you wanted to do. So it's only the communication that we can do, but certain things we cannot avoid or prevent. Thank you so much.
Thank you, Margaret Kamet. Tandazil, are you satisfied?
Hello.
Yes, are you satisfied with the responses?
Actually, it's the team. Apparently, everyone is okay with that.
I'm happy
Thank
if it's
you.
like that. Okay, may we this time around, due to time, team, I know these are the topics we need to discuss now and again. And I'm hoping while we are still going through this theme of communication in our next session, we'll have time to dig more when we are then looking at how then after I've done ACP, when I'm following up, how do I go about following up ACPs? So we'll still come up with certain topics, we'll discuss them more so that we can learn from one another. But this time around, may I give Manzini Hospital this opportunity to present their case for us. I guess you are ready, team. Manzini. Hospital, I believe you are ready for the case. I'm sharing the screen for you now. Okay, Askis Limatata la. I'm sorry. I'm trying to put the screen for you. There we go. You can go ahead, Tandazile, and present the case.
All right. Afternoon, everyone. It's Thandazile Smilane from Manzini Government Hospital, the oncology department, palliative care nurse. Okay, maybe one would love to mention that this case, or whatever we'll be discussing here, it is a position of the facility. It was a case that was discussed during an MDT, multidisciplinary team, or interdisciplinary, if you like to say. So whatever we will be presenting here, it's just a position of management of our client. So we picked one client, a 42-year-old female client. Are we okay? Yeah. Okay, thank you. It's a 43-year-old female client with cervical cancer, recurrent with an advanced at an advanced stage. Okay, so the main concern that we had about this client on this particular because she's currently an inpatient. So this particular admission, it was the glaring social issues. We'll get to that. Then she's also in severe pain, which we scored between 7 and 10. And obviously days are not the same. Sometimes she experiences excruciating pain, but others, it's just a severe pain. And it's been persistent. Also, just recently, she was diagnosed to have a vesicorectal fistula. Holistic assessment, the chief complaint when she was admitted, she had anemia with the HP of 2.7 grams per deciliter. Then she was complaining of the pain with a score of 7 to 10, which was overwhelming. She also had EDVT, which has been there since around 2021 March. For that reason, the patient assumes a supine position, and that's the only position she's able to assume, which has led to developing a pressure sores, pressure ulcers on the perineal area. Are we still together, Sandy? Okay, thank you. Then significant medical surgical history. The client was diagnosed with cervical cancer, stage 1B in 2019. Please note that common practice is that if one is diagnosed with stage 1B, a hysterectomy will be done, and that would be it. And those clients usually do quite well. But with this particular patient, it didn't happen that way. So a hysterectomy was done 2019 May. A CT scan was done December 2020 again, after the hysterectomy had been done, and it was assumed to be successful. But then she showed up at the facility 2020 December, and a CT scan was done again. I think that was still in Babane, which revealed that there is a recurrent cancer. Then she was started on chemo 2021 January. She was put on paclitaxel and carboplatin. She did 6 cycles. After the 6 cycles, she was then sent for chemoradiation. She did the radiation. Then she was supposed to do follow-ups. Unfortunately, the client didn't do the follow-ups, but she only showed up at the facility again March 2021, and that was when she had already developed the DVT. At that time, she was put on high dose of warfarin. Along that management plan, she developed warfarin toxicity. Then 2020 October, after the client resurfaced, 2021 October, a CT scan was done, and it confirmed a recurrent cancer. Considering a prognosis, sorry. Okay, it was confirmed that she had recurrent cancer. Okay. Then for this one, she has been put on chemotherapy, but this time it has been palliative chemo. So she's been continuing with the palliative chemo, but then according to the team, according to the discussions, it transpired that even the chemo is no longer helping her. Therefore, a decision had to be made. We will discuss what came out of that meeting. Then medications, relevant past medications, the patient has been put on slow care at some point. She was put on clexane, warfarin for the DVT. She has been on paclitaxel, carboplatin. Then she has been on bevacizumab and gemcitabine. Maybe for now, let me just leave it at that. But okay, we will discuss what happened with the bevacizumab and gemcitabine, because currently that's what she was getting. But yes, like I said, a decision had to be made yesterday, and a decision indeed was made. Then current medications the client is currently on, she's still on morphine, which she doesn't.
I've lost you, Tandazile. Are you still there? Are you still there, Tandazile? I've lost you. Do you hear me, guys? Or is me who have lost them?
Yeah, we have lost her.
Yeah, we can hear you, but we have lost our sister.
Do you know okay. Okay, Tara said it's not with them. Okay. Give me, oh, Nana.
Hello?
I've lost Tandazile after he finished the issue of drugs.
Yeah. Sorry, we had a lapse in our internet this side.
In Mangolo.
But we're still here. Hello?
Okay, thank you. Continue.
Okay. Then the social history, work status, she's currently not working because she's ECOG4 and she's confined in bed with limited self-care. Occupation, otherwise she is a beautician. That's what she has been doing for quite a long time. Educational level, she did until tertiary. Socioeconomic class, she was classified as middle class, the working class. Marital status, legally so, she is still married, but according to her, she would tell you I'm married, I'm single, depending on who is asking. Lifestyle habits, she actually mentioned that she used to do alcohol, she used to do smoking, cigars, she used to do a bit of clubbing depending on the mood on that particular day. Then relevant health conditions and close family members, we picked that the grandmother had a cervical cancer. Yes, moving on to advanced care directives. With this one, we agreed as a team that as a facility, we need to have a position and actually come up with a system how best we can handle this one. So for now, we are not so much into the advanced care directives. Yes, we do realize that we really need to consider doing it. But then as a facility, we need to sit down and come up with how best we can actually implement this one. All right. Otherwise, mental capacity was assessed partially, I would say, and it's still ongoing because each time we see the client, we do a mental capacity assessment. comments or concerns, we will discuss when we discuss the future plan, further plan. Then review of systems, the temperature, when we filled the template, it was 35.9 degrees C. Blood pressure was 102/66 millimeters of mercury. Pulse was 92, respirations 20 beats per minute. SpO2 room A, it was 99%, which she's doing quite well. Then the pain score, it ranges between 7 and 10. So most of the time the client is in pain. At the issue of morphine, she was educated on how to take morphine so that we can be able to control the pain and at least to try to keep her pain free. However, she has reservations regarding the morphine, including issues of constipation. And now she's saying it is probably causing her severe cramps. So she really doesn't like the morphine. We try to educate. So for that reason, the team has decided to put her on a weak opioid and adjuvant drugs. All right. Okay. All right. Then the ranking of the client's symptoms. We ranked pain 7 to 10. She doesn't have any respiratory distress, no dyspnea. Anxiety, it wasn't assessed using a particular tool, but then the team yesterday agreed that Dr. would see the patient as well, do a complete mental status evaluation, do a PTSD evaluation, do a depression evaluation, which she did this morning. So for depression and anxiety, we left it as query because it was yet to be done by Dr. this morning. Yes, it was done by the social worker and palliative care nurse, but then we felt we needed a second opinion because there were varying assessments or observations. Then drowsiness, most often than not, you would find her drowsy. So the ranking we gave to nausea and vomiting, she hasn't reported nausea and vomiting. Anorexia, there is no anorexia, patient is able to feed. Constipation, I think we agreed that for her, it's severe. Yes, from time to time, we find that she would pass stools, very hard stools, but the constipation is there. And she has moderate dry mouth and poor mobility. She's actually 4. It's overwhelming because the client who said is already ECHO-4. Okay, then we move to current labs. What was done was FBC. So what we picked was the hemoglobin level, which recorded 2.7 grams per deciliter on admission. That's on the 17th of June. And the normal ranges is usually between 12 and 15. So for her, it was too low. Then there was need for transfusion. She did get 3 units of blood. And post-transfusion, the HB was 9.9 from the 2.7. That was on the 20th of June. Creatinine was done as well, and it recorded, it was actually lower than the normal ranges because it was 37. Normal range is usually 53 to 97, so she was 37. There was need to monitor the creatinine because there is metastasis to the bone, so that's why creatinine is being monitored as well. INRs have been done since there is an INR for March 14, which was around 1.04, which is around normal. We had to monitor INR because the client has been on warfarin for quite a long time. So INR has been monitored. March 14, it was 1.04. Then March 25, it was 1.24. Then May, it went up to 4.22. We are still awaiting June results. So now that the INR is elevated, it is for that reason that the client the warfarin had to be withheld. It wasn't stopped, but it was withheld. And again, regarding the warfarin, a decision had to be made yesterday because she still has the DVT. She would still probably benefit from the warfarin. So a decision had to be made. We'll get to that. Imaging and special investigations. An MRI was done 2021 May, which showed soft tissue thickening and enhancement was observed. It also showed destruction of the ischial bone. Then a CT scans were done. 2020, there's one that was done. 2021, another one was done. 2022, it was done. But we decided to focus on the most recent one, which was done 2022, which actually revealed that there's bone destruction with soft tissue mass due to metastasis to the bone. Okay. All right. Then the further plan, which includes the symptom management. Amongst other things that were discussed yesterday, we have mentioned that the client has actually developed pressure areas. So we need to take care of the wound. That's what is actually being done in the ward. We also have to empower the client on how to do it when she goes home. We still continue with supportive care. Then we have to come up with a clear discharge plan and a linkage system for this particular client. Then we need to strengthen the pain management. And also we agreed that, okay, then the client has been having physical pain, but also we need to rule out emotional, spiritual pain. Okay. Also, we agreed yesterday that a PTSD should be done, assessment should be done. Major depressive disorder should be checked as well. A mental status examination should be done. Those are some of the things that were covered by the SMO this morning. Otherwise, the client is expected to continue with Zometa every 2 months, zoledronic acid every 2 months. And also the client is expected to continue with the anticoagulants at least twice a week for now and monitor how the INR, how the toxicity responds. So we are going to put her back on warfarin, but we are going to give it twice a week. So the first dose was given yesterday, and she has to get another one. It will be done like it will be checked like every week. Then INR will be monitored as well. Also, we need a family meeting with the biological family, and also with the aunt, also with the client. One may want to highlight here that the social issues that we picked when the client comes. Actually, when she came, the main reason she was admitted, it was that she doesn't want to be home anymore. And I think it took us by surprise because we have always perceived the biological family support as like the best, as the support any client would have loved to. But when the client was actually admitted, she requested the admission. She said she didn't want anything to do with them. She didn't want to be home anymore. So on admission, she was brought in by the family. Amongst them, it was the mother who has always been there for the client, the brother, the younger brother, he has always been supportive. They brought in her, but then she insisted that she doesn't want any one of them to lodge or to be with her in the facility. She just needed some space from them. It took us by surprise anyway, but that's what the client wanted. So she insisted that from that day, she wanted to be taken care of by the daughter. So the daughter was called in to take care of her. And obviously, the daughter as well got not necessarily emotionally or psychologically tired, but physically tired. So then we had to check with the client whom she could be comfortable with having again. Then she cited that she would be comfortable having an aunt from her father's side. So then the aunt was brought in. So to this date, the client is still here and she's still insisting she doesn't want to go home. The only way she would go home, it's actually when she would be able to take care of herself. That's the one scenario, or as a dead body. That's what she said. Okay. So, but then do note that the family, the biological family do come to check on her from time to time. And guess what she does? When they come, most often than not, she pretends to be asleep. Yeah. Okay, then we also had to check how was the relationship between her and the husband, because it's very rare to hear her talking about the husband. We have never, I for one, have never seen the husband come to check on her. Then she said, like I mentioned earlier, she said if anyone could actually help identify or locate the husband, meaning she doesn't even know where he is. So she mentioned that she got married around 2010, then things went south that same year. Otherwise, the husband has always been supportive, even though they had those issues. But then the relationship wasn't so good. So currently, she doesn't care whether the husband comes or whether he doesn't come. In fact, we checked, has the husband ever tried to check how you're doing? Actually call and find out how you're doing. She said, the husband said, actually, she had to, at some point, she went to RFM to check and she found out that the patient was already discharged, but she never followed up. Then again, the husband said, I did come to check you at Moneni, but they said you were already discharged. He never calls. Okay, but I think one conflict one would want to note is that the husband thinks this is a traditional nang. So he's saying if he were to assist in any way, it would be for him to take the client to a traditional healer, to which the client is not comfortable with.
Thank you. I wish we can go more and more and more. But
yeah,
by how fast we need to be out of the system.
Okay, all right. So I think for now, I think I've highlighted what the social issues are. So then we are still doing those assessments, and amongst other things that we had agreed on at the family meeting, which is yet to take place. We are still to call the family and discuss with the aunt, because there is an aunt now who's willing to take her in, but to take her. But our issue was the aunt will be leaving, going back to Joburg. And also the aunt was saying if she takes her, then the family, the biological family shouldn't know that she's actually taking the client. So that's what we are trying to come up with. We have to find a common ground between the biological family, who has always been there, and the aunt who is willing to take her in, and what the clients want now. Okay.
What a wonderful.
Then I think, yes. Then another decision, the decision that I said was we had to be taken, is the decision of stopping active chemo, because we agreed that the client is not benefiting anymore. She is ECOG4, and rather than having better CT scan results, it's showing that it's progressing. So the chemo, the active chemo, it was stopped. A decision was taken to stop. Otherwise, when she came, we thought that it was withheld for her to stabilize, then would continue. But then yesterday, the team agreed that we had to stop the active chemo, otherwise continue with a supportive care and palliative care. Then we need to link this client to Hospice and Eswatini breast and cervical cancer networks. Breast and cervical cancer networks actually offered to support us with home visits as well. I think that would be it from our team, not unless there will be additions.
Thank you. Thank you so much. Thank you so much, Manzini Hospital, for such a wonderful case. Anyone with a question? What I'm seeing here, I'm seeing a patient with one direction or 1 or 2 steps left, which is active dead, and already now is at end of life, of which end of life is already started. I've noted that the patient has already given you the advanced care plans that she wants, and she changes when she wants. So I think it's a matter of documentation. Already the patient was leading you of what she wants you to do for her. But I think there's a lot the team can extract from you. Let me give everybody a chance to comment and ask and help Manzini Clinic do better than they are doing now. What can we suggest for them to continue, and what can we ask that we did not ask? May I give ourselves at least 5 minutes to comment in this one? You are free to write on chat or raise your hand, and then you share your view, your comment for Manzini Hospital concerning this case that are happening with advanced stage cancer. Yes, Maria Gamete.
Thank you, colleagues, for the presentation for the case. For me, I feel it is a training one as well, but thank you for the good work that you are doing and for the decisions, the forward decisions we are making in the care of this patient. I just want to highlight this one thing. I think this patient also, like Sandile has said, end of life has begun. She needs to be assisted with another decision-making process on the issue of burial. Because now she's saying, I only want to go to my biological family as a dead body. And the things that she's doing, not actually cooperating with their visit and everything, is closing another, it's a barrier on its own. So we are not sure if she will die. Will they be willing to take her? And then there is the issue of the husband we have raised here, and the husband is still in her life. So she needs to be sure about facing death and being buried in the right place, even for her daughter to be at peace, because there might be some quarrels if she does pass away under these circumstances. I know it's a difficult thing to do, but something that we need to face because it is quite imminent. Thank you.
Thank you, Margaret. Anyone else? There's another thing I noted concerning the pain. That's the abdomen then comes with cramps and stuff because of morphine. In my experience in the practice, what I've noticed is that, okay, abdominal cramps can be there. If it's a cramp, maybe you can get antispasmodics, then combine them with the morphine. But the morphine is the best in terms of controlling the pain other than increasing the polypharmacy, but it's okay with the adjuvant. But what I've noticed is that if you are prescribing morphine with bisacodyl only as a laxative, especially to bedridden people with ECOG-4, the physiology then says that once you are bedridden, the GI system peristalsis also goes down. Yet even morphine, when it comes, it deals with the peristalsis too, and it reduces it. So what will usually happen is, if you give bisacodyl, which is a stimulant, then what it does, it makes the gastric to lift the peristalsis again. So to a bedridden patient, then what happens is that when then the gastric motility is increased by this bisacodyl, it pushes that hard stone inside. That's why your patient is passing stool that is so hard. And that's the stool that makes the patient to refuse the morphine. And most of the time, if they continue to push that hard stool, they end up developing piles. So what is recommended then is that we can encourage fluid intake, but especially now in winter, it's not guaranteed. So I can encourage that say morphine will be the best drug for her, especially this time at end of life. It will help her, and it might be the only drug that we will end up having until she dies. So we need to combine the laxative, have the stool push and the stool softener. If it's possible, get liquid paraffin or lactulose, something that will lubricate the stool, because it is very hard, and this bisacotin makes the body to push this hard thing, and it becomes so painful for the patient. So they end up refusing to take it, yet it's the best one to help the patient, especially the liquid one, because at this stage now they will reduce PO things. So you'll find that the liquid one will be the best one to use for such a patient. I mean, I would request that find out the issues of the cramping. You might find that what Dr. Dlamini called this fecal impaction, it will happen. So I will say go towards the issue of finding a dual laxative, a stool pusher and a softener. It will help the patient to have pass stool very well. Thank you. I don't know if anyone wants to add something. Otherwise, there are a lot of things to be dealt with, but I think the plan you are having is going to help you. And the issue that the patient doesn't want to meet these people, you will find that we need to work on the spirituality side of the patient too. Let's find umfundisi for her if she wants that. But we cannot put a blind eye on conflicts. So we need to sit down with the patient, understand what the family has done, you know, because if she will die in pain, he will leave other people in pain. So let's treat that one. Let's not put a blind eye on it. Find out what makes the patient not to go to his family, and why is the husband running away. So I think you are doing a great job on that side. So that will be my input. I don't know anyone else. I have 4 minutes left with me. Anyone has something to add? Okay. If there's nothing else we can add, thank you so much, Manzini Hospital, for such a wonderful case. It is very eye-opening, and it is very important for us to understand the great work you are doing there. May I also encourage the team to continue with the work towards helping their clients set up their advanced care plans, as the patient usually they want. Especially this one has already started to call for an advanced care plan. In chat box, we have shared a feedback link. Kindly click that link before you exit when you end the session, so then you can take the 2 minutes and share the feedback with us. It helps us to improve and do better next time. And also, may we announce that we will have our next session on the 13th of July. So on the 13th of July, we will look around a case presentation, and also we will be looking at ECHO. What is this platform we are in, so that we may all understand this platform we are in, so we can do better and participate better in it. So we will take just that one session as a break from the series we are in. After the 13th, we will then continue with how then do we follow up with the advanced care plan after we've initiated it. It means the ongoing goals of care. We will finish that topic after the 13th. But on the 13th, we will look around the issue of ECHO, this platform itself, with the help of our supporter, India. And then we will have a case presentation. So thank you so much, colleagues. If we come to you and request you to share a case with us, it's for learning purposes and also to support you and see how we can support you better. So we have learned from Manzini Hospital on how they are doing very well. I think we can copy something from them, and we can learn something from them. And I hope they also have learned something today. Thank you so much for our presenter, Messi, to be there for us even today. And thank you so much for our IT supporter, Alina and team ECHO India. Thank you so much to be part of this session. May the Lord God bless you all as we depart this session. But please kindly remember to click the link when you exit. Thank you.
Thank you, Mr. Sandley. Bye-bye, everyone. Thank you for joining.
Thank you. Bye-bye.